Okay, so next we move to the CNS system, or you can just say the neurology section. Now what we really have for here is just 10 very piercing and bad fights per week in a damp season. Yes, that's it. That's the scene for the CNS. 10. T stands for tingling and numbness. V stands for vertigo and vomiting. Piercing. F stands for fasciculation. So right now you get the tingling, numbness, fasciculation, vomiting, and vertigo. Then we get bad. B stands for blindness, A stands for aphasia, and D stands for diplopia. Next up, we have fights per week in damp season. Fight stands for fits, G stands for gait, H stands for headache, T stands for tremor, and S stands for stiffness in neck. Next, we have per week, which stands for paralysis and weakness, and then DAMP, which is depression, anxiety, memory loss, and palpitations. And season stands for syncope. So tingling, fasciculation, numbness, vomiting, vertigo, blindness, aphasia, diplopia, fits, gait, headache, tremors, stiffness in neck, paralysis, weakness, depression, anxiety, memory loss, palpitation, and syncope. These are the really complaints related to CNS. Now let's dive into the CNS scenario by drawing a stage where everyone is just fighting. And you know what? It's a very piercing and bad fight. In this fight, you'll see everyone. Bodybuilders, from the Undertaker to the Triple H. Also, you're going to see boxers, babies, monkeys. What? Babies and monkeys as well? Sure, you're going to see them all. After all, it's very piercing and bad fight. So we draw a stage here, and on that stage, we draw two wrestlers who are just fighting for their lives. You know the wrestler with the red pants? Oh yes, he's Shock Michaels. Now why Shock Michaels? That's because he appreciates feeling of shocks, like tingling and numbness in his legs. That's why we have drawn his red pants along with shock symbols. Oh man, Shock Michaels is really punishing him hard. So hard that even the boundaries of the stage are flicking, just like fasciculation. So numbness, tingling, and fasciculation, we have covered all three symptoms. Now, if the patient tells you about the fasciculation, better think of motor neuron diseases. And if the patient tells you about numbness and tinglings, go for neuropathies. Next up, here comes 175 pounds, Hemi Mysterio. And you know he flies like a butterfly and stings like a bee. One thing you're going to notice is the half of the body is red. That's why he's called Hemi Mysterio. This means he's actually flying with the half of the body not even working. This is hemiparesis, and this hemiparesis falls under the category of paralysis and weakness. So let's discuss paralysis and weakness in a little bit detail. Now, if a patient presents with a muscular weakness, it has a lot of causes. For example, upper motor neuron lesions, lower motor neuron lesions, combined upper and lower motor neuron lesions, peripheral nerves disease, or just neuromuscular junction disease, or just the diseases of the muscles. Now, if we talk about the diseases of upper motor neuron lesions, we got stroke, transverse myelitis, primary lateral sclerosis, and progressive pseudobulbar palsy. While the diseases of lower motor neuron include poliomyelitis, progressive muscular atrophy, progressive bulbar palsy, and if you try to find the causes of combined upper and lower motor neuron lesions, you get ALS, cervical myelopathy, and syringomyelia. If we talk about the diseases of peripheral nerves, we get diabetes, Guillain-Barré syndrome, Friedreich's ataxia, peroneal muscular atrophy, or some alcoholic neuropathy, folic acid, vitamin B12 or B6 deficiency. Now, all these fall under the category of peripheral nerve disease. If we talk about the neuromuscular junction diseases, we get myasthenia gravis. And if we talk about the diseases of muscles, we get muscular dystrophy, hyperthyroidism, hypothyroidism, Cushing syndrome, and familial periodic paralysis. Also, you're going to count polymyositis and dermatomyositis as the disease of muscles. Now, when you're ready to take the history, you'll ask about the onset. If it's with few minutes, this is stroke. If it's taking few hours, this is poliomyelitis or transverse myelitis or GBS or stroke due to thrombosis. If it's taking weeks or months, that is actually motor neuron disease, muscular dystrophy, familial periodic paralysis, or acute thyrotoxicosis. After asking the onset, you're going to ask the type of disability. For example, you're going to ask if they can easily go upstairs or stand. And to remind you of that, we have drawn these stairs beside the show. Now, if the patient cannot stand or go upstairs, that's because of the weakness of proximal muscles of the lower limb. If the patient cannot go downstairs or cannot sit, that's the weakness of distal muscles of the lower limb. Now, if the patient cannot comb their hair, that's the weakness of proximal muscles of the upper limb. And if the patient cannot write or hold something, that's the weakness of distal muscles of upper limb. As a rule of thumb, proximal muscles are usually involved first in the myopathies. Now that's enough talk about the muscular weakness. Now you're going to determine the pattern of weakness. If it involves one half of the body, just like we're seeing in hemimestereo, that's stroke. Now the weakness can also involve one muscle or a group of muscle, and this is neuropathy. We show this by drawing one muscle of the hemimestereo with the red color. Next up, as you see, when the shock Michael hits his opponent, he cannot move his arms, and his arms are just freezed. We're showing this by coloring his arms with a red color. Now, if there is weakness of both arms, this is going to present as facial scapulohumeral muscular dystrophy, or ALS, or GBS. Wait a minute. It's not only the arms, it's also the hip girdle muscles. So when the patient complains of the weakness of hip girdle muscles, better think of poliomyositis, dermatomyositis, progressive muscular dystrophy, or just metabolic or hormonal disorders which are actually leading into myopathies. Next up, we're going to draw the CEO of this 10-fight stage. Here comes Nick Khan, and you know what's wrong with him? He cannot walk properly. There's something wrong in his gait. So you're going to ask about the gait of the patient. Has it changed recently or not? Well, there are different types of gaits. For example, penguin gaits, you can have circumduction gaits, and so and so. But we're really not going to discuss those all gaits because they don't fall under the category of history taking. Right now, we're just focusing to diagnose the disease on the basis of history. So long story short, just ask them if there's a change in the gait or they can walk properly. Next, you're going to see the CEO wears these bangles, one on wrist and one on ankle. And these bangles are going to tell you about the wrist drop or the foot drop. Now, the distal limb weakness, for example, foot or wrist drop, is seen in familial peroneal muscular dystrophy. Now, let's draw another wrestler with a cast on his leg. Now, this is going to represent the clubbing of foot, and we'll come back to you later. Just hang in there, baby, and keep screaming. Now, I wonder what kind of wrestling is that without any commentary on it. So let's add a desk for the commentators behind the stage. So as you can see, we have added 3 different folks, and there is a mic in front of them, and that mic is red. I mean, it's useless, it's not just working. So what does that mean? It means you cannot speak? Is this dysphonia or dysarthria? Who knows? I guess both. Also, we're going to add an apple, and guess what? It's again red. They cannot eat it. And if they cannot eat it, is this dysphagia? So in a nutshell, if there's a patient with dysarthria, dysphonia, and dysphagia, and he presents with the muscular weakness, it's good to think about bulbar palsy or just motor neuron diseases, bulbar poliomyelitis, and diphtheria. Next up, we have a third person with the weakness of eyes. So we represented his eyes with a red mask. So if you really come across a patient with the weakness of eye muscles and he is presenting with the complaints of double vision, drooping of upper eyelids, or squint, better think of lesions of the third, fourth, or sixth nerve, or it could be myasthenia gravis, thyrotoxicosis, or myotonic dystrophy. And here's a plot twist. The desk of the commentators was built on the grave of a famous wrestler known as The Undertaker, and he was also known as the Dead Man. Now watch out, watch out, watch out! Who's this? This is the Undertaker. Oh my god, that's unbelievable. He has just popped his head out of the desk. Oh. And as you see a head, you're going to ask the patient if they can hold their head. Now, if there's weakness in holding the head, that could be because of polymyositis. Or if there's weakness in lifting the head from the pillow, that is because of the sternocleidomastoid muscles. For example, in progressive muscular dystrophy or motor neuron diseases and syringomyelia. So asking about holding the head is really important. Now let's go back to our young fellow who was constantly in pain with a cast on his leg. And that cast is going to represent club foot. So if there's a patient with a club foot or deformity, better think of the peroneal muscular atrophy, Friedreich's ataxia, or just hereditary spastic paraplegia. Now, as I mentioned earlier, this is a very, very bad and fearsome fight, and almost everyone is going to take part, including these young kids. So let's draw these green babies that are going to tell you about the pattern of weakness. It could be generalized, it could be ascending, could be slowly progressive, it could be chronic. Now, if you take a moment and look at these babies, one of the babies is with the barbell. Now, he is a chronic gym boy. So that baby with the barbell is going to represent the chronic paralysis. Now, if you see the second baby on the stairs, he is just trying to move slowly. Now, this is going to represent the slowly progressive pattern of weakness. If you see the third baby, that's trying to ascend onto the stage. So he's going to represent the ascending paralysis. And finally, we have a fourth baby that is already sitting on the top. This is going to tell you about acute and episodic paralysis. Now, the chronic paralysis is because of polymyositis and spinal muscular atrophies. Slowly progressive paralysis is because of the motor neuron diseases and muscular dystrophy. Ascending paralysis is because of the Guillain-Barré syndrome, and generalized paralysis that involves acute and episodic pattern, that's because of periodic paralysis or thyrotoxicosis. Now we draw a pair of these security cameras, and one of the cameras is just down, and that is going to represent the drooping of the upper eyelid. And this is seen in myasthenia gravis and myotonic dystrophy. Next, where there are bad piercing fight, there are always traumas associated with death and wasting. So here's a wasted person lying beside the stage. I know, he was caught up in a big blow. When you take parts in piercing fights, that's very natural. So remember to ask about the wasting of the muscles. Then we're going to draw the diarrhea from this dead man, and just before the moment he expired, his red handkerchief from the neck just dropped onto the ground. So that means if there's a patient with a history of sore throats and GI symptoms, and few days later it presents to you with a muscular weakness, you must think about transverse myelitis, Guillain-Barré syndrome, and poliomyelitis. Also ask about the history of rash that is seen in dermatomyositis and SLE. Next thing, you're going to ask about the fever. So we set this whole stage on fire to double the spice. Why fever? Well, good thing you asked. It carries the same significance as sore throat or GI symptoms in context of transverse myelitis, GBS, and poliomyelitis. One more thing, there must be pain and bloodshedding in this fight. So we're going to add a big banner of pain. Yeah, more pain. Okay, so you're going to ask about the pain, and in this case, you're going to ask about the pain in muscles. That is seen in dermatomyositis or polymyositis and in early stages of neuropathies. After seeing this whole fight and pain and bloodshedding, one of the persons around just lost his consciousness and started shaking like anything. That's the fits. So to tell you about fits, we draw this fits man from the genitourinary function playland. Do you remember that? The person with the fits and rash and memory loss and timing of fits, and its two friends, one with the fever, one with the headache and anxiety, one with the paralysis, and you're also going to ask about the TODS paralysis. Well, that's it. Well, these are the associated symptoms that are common to both the CNS system and the GU system. In the GU system, there are fits from hyperuricemia. In the CNS system, there are fits other than hyperuricemia. So what you're going to do is ask the witness to tell you the description of fit. You're going to ask about a cry or fall to the ground or tongue bite or cyanosis, or just ask about the flinging movements of the limb, loss of bowel or bladder control. Ask the witness if the patient just slept after the attack of fits, or if the witness tells you about the brief absence, that's absence seizures, or if the witness tells you about the involuntary muscle contractions, that's myoclonic jerk, or if the witness tells you about sudden fall or loss of motor tone, that's because of the akinetic seizures. Ask the patient or the witness about auditory, olfactory, or gustatory hallucinations. These are seen in temporal lobe or psychomotor epilepsy. Ask about the Jacksonian seizures and try to rule out epilepsia partialis continua. Now, if there's a young tense female without any loss of consciousness and she presents with a deep sighing respiration and there are also irregular movements of the limbs, it's good to think about hysterical fits. And finally, ask about the precipitating factors, for example, anxiety, emotional outbursts, or just flickering lights. And that's it. We have covered fits completely. Next, we're going to talk about the headache, and for that, we're going to draw these two boxers. And to help you understand better, we're giving one of these wrestlers a headache cap. This headache cap is a recurring symbol for headache. Now, when you see a patient with headache, ask them since when. Ask them the site. If it's generalized, that's tension headache. If it's on one side, that's migraine. If it also involves one eye with lacrimation and rhinorrhea, this is going to be cluster hemorrhage. If first it's localized and then it spreads to the whole head, that's because of intracranial pressure. If it's the worst headache of your life with the predominant occipital localization, this is subarachnoid hemorrhage. If it's just involved the occipital region with the neck stiffness, this is meningitis. Also remember, neck stiffness can also be seen in subarachnoid hemorrhage. If it involves the temporal side, this is temporal arteritis. Then you're going to ask about the corrector. If it's band-like, pressing, squeezing, this is tension headache. If it's throbbing, it's migraine. If it's dull, it's cluster hemorrhage or meningeal irritation with the eye and ear discharges. Ask about the severity of the headache and then followed by a diurnal variation. If it's nocturnal, that's because of cluster headache. If it's early morning, that's migraine, hypertension, and intracranial pressure. If the headache starts getting worse in the morning, reaches maximum intensity at noon, and then subsides, this is frontal sinusitis. If there's no specific timing, this is tension headache or meningeal irritation, or just referred pain from eyes and ears. Next up, you're going to ask about the prodromal symptoms. For example, anorexia, nausea, lights, transient hemianopia, hemiparesis, or just speech disturbances. And all these prodromal symptoms are seen in migraine. There are some aggravating factors which are going to help you rule in or rule out different types of headaches. For example, bright light, tension, cheese, chocolate, these are going to aggravate migraine. Fatigue and anxiety, these are going to worsen the tension headache. Alcohol, this is going to worsen migraine and cluster hemorrhage. Coughing and straining, this is going to worsen the intracranial pressure, which is just causing headache. Now, if you're reading books and there's a lot of strain in your eyes, that's because of refractive errors of the eyes. If there's high blood pressure, this is headache because of hypertension. Noise and bright light can worsen meningeal irritation, as seen in subarachnoid hemorrhage and meningitis. And if the headache gets worsened when you lean forward, that is because of sinusitis. Now that's a long lecture on headache. Why not shall we talk about the associated symptoms? Oh yes, of course we will. So first of all, it's fever. The boxers are flamey. They're fighting in the flames. Now, if there's fever and headache, that is more likely because of meningitis or encephalitis. Next thing, you're going to ask about water from the postnasal side, water from nose, and water from ears, and water from eyes. Now, if there's watering in the postnasal side, that is just postnasal discharge, and this is seen in sinusitis. So the headache is because of sinusitis. While if you see water from the ear or tinnitus or deafness, that's seen in otitis media, mastoiditis, or temporal lobe abscess. Besides this all, if the patient says they have watery eyes and watery nose, now that's lacrimation and rhinorrhea, and that's seen in cluster hemorrhage. Next associated symptom, oh yes, there's a wrestler who drinks a lot of water and then splashes it everywhere thinking he looks cool. Presenting to you triple vomitus. But wait. I don't think it's water. I think it's vomitus. He's just splashing vomitus everywhere. Ew, gross. So this pressure vomitus is going to tell you about the projectile vomiting that is most likely seen in CNS causes. So if there's a patient with the projectile vomiting, drowsiness, confusion, or coma, and he presents to you with a headache, that's because of raised intracranial pressure due to space-occupying lesions or just meningeal irritation. To learn more about vomiting and its causes, head to my GIT section and see the second input terminal of that weird machine. Next up, the triple vomitus is wearing neck protection. Now this is here to remind you of neck stiffness. Now this neck stiffness is usually seen in meningitis or subarachnoid hemorrhage, and in rare condition it's seen in hypertension, refractive errors, or the space-occupying lesions of the posterior cranial fossa. Now, as you see these two boxers fighting so fiercely, one of the boxers punches the other so hard that his glasses just fell off from his face. Go red, go! Go red, go! Beat him! Knock him off! Well, these falling glasses are there to remind you of refractive errors of the eye. Ask the patient if they had their eyesight checked or they regularly wear their glasses. Next up, we draw this syncope windmill. And to learn more about this syncope windmill, head over to my CVS unit. Next up, we're going to draw a vertigo vortex behind the stage. Yes, a vortex that is going to represent vertigo. Now, vertigo is just revolving, and the patient is going to tell you, I'm spinning. Or if I'm not spinning, the world is spinning. Now, if we talk about the common causes of vertigo, we can have psychogenic vertigo. We can have vertigo because of acute labyrinthitis, Meniere's disease, or benign positional vertigo. Some tumors can cause vertigo, for example, acoustic neuroma. Otitis media can cause vertigo. Vertebrobasilar insufficiency, cervical spondylitis, and systemic diseases, for example, hypertension, anemia, high-grade fever, all these can cause vertigo. Now let's talk about the associated symptoms of the vertigo. Now this vertigo is brought along with a monkey out of nowhere? What is that? And now this monkey is really going to appreciate the spinning world around him. While this monkey spins, or the world around the monkey spins, he is just splashing vomitus everywhere. So if you see a patient who complains of the world spinning around him, along with vomiting and nausea, that's because of acute labyrinthitis or Meniere's disease. It's also seen in migraine. Oh, it looks like the vertigo brought this whole family of monkey along with it out of nowhere. Anyway, let's continue. Here we can see another monkey just sitting on the top of the paint banner and he is just plugging his ears. Is he having some kind of chronic pain or something? Now, I think it stands for the ear symptoms. Ask about the symptoms of ear disease. For example, deafness, tinnitus, or ear discharge. Now, that's really seen in otitis media, acute labyrinthitis, Meniere's disease, acoustic neuroma, and cerebellopontine tumors. Now, the face of the monkey just turned red. Is he scared of these piercing fights? Who knows? This red face is going to tell you about the facial weakness. If there's facial weakness, paralysis, double vision, along with vertigo, that's because of vertebrobasilar insufficiency. Also, you're going to see this monkey is thinking about something, or he's just anxious, or just panicked to see all these piercing fights. Well, who knows? All I know is this seems anxiety to me. Ask about symptoms of anxiety in a patient with the complaints of vertigo. If there is anxiety, ask about palpitation, numbness, fatigability, anorexia, insomnia, and failure to take a deep breath. If all these symptoms are positive in conjunction with the vertigo, that's hyperventilation or just psychogenic vertigo. Next, what we have here is a monkey who is just giving a very nice pose. I like your pose, man. And he's also wearing something in his neck. That is neck stiffness. So while taking history of vertigo, ask about the effects of posture. Now, if the vertigo is related to the position of head or body, this is just benign positional vertigo or cervical spondylosis. On the other hand, if you appreciate stiffness in neck, with or without pain in joints, that's because of cervical spondylosis. So in a nutshell, in cervical spondylosis, you can also have vertigo and there's effect of posture and stiffness in neck. Next, we draw two more monkeys that the vertigo vortex brought them with it. Now the monkey at the back is just palpating the monkey at the front. So you're really going to ask about the attacks of palpitation. If there are attacks of palpitation and vertigo, that's because of the cardiac cause. And it could be because of cardiac arrhythmias. Now another thing you're going to notice about the monkey at the back is he's wearing a headache cap. So ask about the history of headache. If the patient complains of headache along with vertigo, go for migraine, acoustic neuroma, or just cerebellopontine tumors. And finally, we have depression, anxiety, memory loss, and palpitation. You'll notice that we have already discussed these in conjunction with the other symptoms. For example, we have already discussed depression, anxiety, and memory loss along with fits, and palpitations along with the syncope windmill. So that's really going to end our discussion on CNS. What do you say? How about a quick recap? Well, as far as CNS and neurology are concerned, you're going to ask about paralysis and weakness associated with tingling, fasciculation, numbness, vomiting, vertigo, blindness, aphasia, or diplopia. Then you're going to ask about fits, gait, or just change in gait, headache, tremors, syncope, stiffness in neck, or depression, anxiety, memory loss, and palpitations.